Good morning, good afternoon, good evening, wherever we are reaching you. My name is Shubayan Sanatani, and I'm your host on this third edition of Let's Talk SADS Live. And this is our Canadian SADS Foundation broadcast. We are relatively new to this space, but enjoying it. We've had some wonderful conversations. Happy spring, everybody. And I'm excited about our broadcast today. A reminder, this is really about collaborative learning. So we welcome your questions and your comments and your feedback. We're not delivering patient-specific care, but we're really trying to drill down on how to improve the care of patients with SADS conditions, sudden arrhythmic deaths conditions. And I'm here by the good graces of a number of people, including Pam Husband, the executive director of the Canadian SADS Foundation, Evan, Aaron, and Alice Lara, all of Canadian and American SADS Foundations, are in the background pulling my strings to make sure that I don't fall off my perch. And so thank you very much to all three of them for getting me going and for keeping me going. So you'll hopefully remember or be picking up on a little fun side bit that we do, a Canadian fun fact, and today is no exception. Today I want to tell you about an individual who is credited with invention of the pacemaker. And in fact, when you read some articles about the pacemaker, or if you get a Google search, this gentleman doesn't necessarily show up, and there's a lot of focus on Earl Bakken, who is credited with the first battery-operated pacemaker and who was instrumental in forming Medtronic. This is an individual that was also at the Banting Institute, and I'm just going to show you here. Hopefully, I'm sharing this now. This is one of these very early heart stimulators, and you could see you could dial up the heart rate, and there is an extension cord, or there's a plug, so this actually plugged into the wall. And this came to be because Wilfred Bigelow, who was a surgeon at the time, he was working on hypothermia, or cold temperature, and cold temperature caused the heart to slow. And so they enrolled the help of this Dr. John Hops, preferred to go by Jack, and he was a biomedical engineer in the institution, and they recruited his help. And there you see the sign says mobile cardiac resuscitator. Remarkable what was considered mobile back then. And so John Hops is really credited with the first electrical stimulation of the heart and what came to be the pacemaker. So fun Canadian fact. And just a reminder, because we are keeping track, and we're hoping that our audience is keeping track. We talked in our first episode about George Mines, who did some work in Montreal, and then Jenna Kidd Trout, who was recently recognized on International Canadian Women's Day as the first Canadian female physician to be licensed in Canada. So it's a great pleasure to introduce our guest today. And Dr. Michael Ackerman needs really no introduction. He looked about like this when we met about over 25 years ago, when he and I were both pediatric cardiology fellows. He was, of course, at the very world-renowned Mayo Clinic, whereas I was here in the slightly less renowned but also excellent Vancouver program. And Michael Ackerman really needs no introduction. He's the Windland Smith Cardiovascular Genomics Research Professor of Medicine, Pediatrics, and Pharmacology at the Mayo Clinic. And he's been the leader of the SADS Foundation in the US since 2006, and that has really flown by. He's been recognized by several with several distinguished awards at the Mayo Clinic and the Heart Rhythm Society, as well as the American Academy of Pediatrics. Most importantly, I consider Mike a mentor in the space of sudden arrhythmic death conditions and a good friend and collaborator. So let's bring Mike into our studio. Today we're going to talk about activity and where guidelines meet reality. So pleasure to have you here today, Mike. Thank you so
It's
much.
it's great to get to be with you, Shu, and congrats to you and to SADS Canada for your uh, starting this Let's Talk Live, Let's Talk SADS, and third episode. And I'm honored to be number 3. I usually like to be number 1, but that's a whole nother conversation. But I'll take third place.
You are the first non-Canadian guest here. So, and speaking of threes, because we have a saying in medicine that's very scientifically based that things come in threes, and Mike and his team have just celebrated their 3-year anniversary, and they have been doing SADS live since the pandemic started.
Yeah, it's been incredible. We launched it March 2000. It's 2020. Yeah, March 2020. And this Friday we'll be having our 114th episode. And so what started to be there as a voice of reassurance and calm, as there was, as you remember, profound anxiety among the community of SADS families. What's going on? What will this virus do to their long QT? And then a year later, what will the vaccine do to their long QT or their CPVT? And then we just kept going as the purpose of the starting point changed. We still knew that there was a tremendous need to have these kind of touch points with the families and meet the needs of the families through this social media venue. And I'm just really excited that you guys are doing it now as well. I think it's a wonderful collaboration. So congrats.
Well, yeah, thank you, and congrats to you. And we both rely on many of the same infrastructure and support people who I can't thank enough. Now, this is going to be a bit of a segue. In those early COVID days, you were very vocal about some college athletes and these claims that they were very high risk of sudden death from myocarditis. And you were vocal and visible, and in some regards, you saved the season. Tell us a bit about that.
Yeah, I guess they say I don't. It's not self-ascribed. It is ascribed to me that I saved college football and the University of Alabama, the national champions of that save season. Their newspaper are the ones and their reporter that we saved college football. But it really was just somebody needed to step up and stand in the gap and say, wait a second, kind of like Tom Hanks in that movie Big, one of my favorite movies, raises his hands in that office room and says, I don't get it. I don't get it. I don't get why we're doing it this way and why there's this rush to judgment. And as you know, some of it started with just observations from cardiac MRI studies that, frankly, I thought there's no way this can be accurate out of Germany, and then also out of University of Michigan, I believe. And I think it was Alabama who Ohio State paper. And it was Alabama who then ended up beating Ohio State for the national championship. So I think it just helped things. And I happened to be sought by the Big 12 at that time to meet in front of all of their presidents and just give a different perspective. And that perspective changed their vote. And had they voted no, it's likely that all the other conferences, SEC, would cancel and so forth. And so it changed. And now here we are. And it's wonderful when, your gut feeling based upon past experience and knowledge turns out to be right. And I think we turned out to be very right on that call.
Yeah, no, absolutely. And the segue I'm referring to really is that you're very much about doing what's right based on data. And so today our theme really is about activity and guidelines and pushing, pushing the back on those a little bit. And before we get into that, I want you to help us understand, because not all of our audience necessarily understands these big statements that come down, these guidelines. What are they? What's the process? Can anyone just write a guideline? Give us a sort of a Cole's notes on these
Yeah.
documents that then are very powerful and influential.
Yeah, there's guidelines and then there's guidelines, right? There are those guidelines that come from studying thousands and thousands and thousands of patients with heart failure, and then trials, randomized, blinded, controlled, and the verdict is clear. And then the guidelines say, thou shalt treat with drug X because drug X works, or thou shalt implant a defibrillator class 1 indication because we've studied thousands of people with heart failure and EF of whatever. And once you descend below that line, class 1 indication. And then there's guidelines, as in those that are grounded in well-intended but expert opinion. And that's largely the world of sports cardiology and sports participation guidelines, for which what guided you and me from our transition from fellowship to faculty. I joined the staff of Mayo Clinic in 2000. The guidelines were really clear. Unless your heart is perfect, no competitive sports, period, nothing. And then I grinded my teeth being invited to the next guidelines in 2005. That was called Bethesda Conference 36. And it was really my clinical mentor in chief, David Driscoll from Mayo Clinic, who got me onto the guidelines, being 5 years into faculty, really probably not yet justified on merit. And so I'm very grateful to David, to Dr. Driscoll. And then that was an eye-opening experience, because you see, when there isn't the data, like I said, thousands and thousands of patients have an assembly of a cast of characters. And those characters can be very influential. And one could look back at the 40 experts that comprised that guidelines and see the voices and the perspectives. And as invoked, and as we were very transparent in those guidelines, that we're practicing the art of medicine. And I've often commented that when we tell a patient you're disqualified from the sport that is your passion, do we then qualify that and say, and by the way, I'm being rather artistic now in my expression with you as a family? Do we show them what is the data or the lack of data in those recommendations? So back in 2005, we cracked the door open with a little wiggle room, and that door opening was really me, where we said, unless your heart is perfect or the genetic heart disease is confined to just your genetic code, then no competitive sports, period, except for the safe 6. And we added 6 little things that you could do. And no offense to those who love cricket, but that was one of the safe 6 things, for which the cricket players, they're really, really ticked off that their sport got classified as an ultra safe sport. But that's where we were in 2005 at that first round of guidance. But me and people like me, you were one of those. We were very alone back in those days, because even though that's what the guidelines said, that wasn't my practice, because I just felt we were doing wrong by our families. And part of that perspective was guided by families coming to me disqualified and seeing the damaged goods that were coming on arrival. I mean, profound damaged families. Now, those families who got disqualified moved on. Well, then I never saw them, but I saw an increasing amount of the disqualified whose lives literally became train wrecks. And I just said, we have got to be able to do better than what we're doing to these families.
Yeah, no, absolutely. And you started describing the, guidelines, maybe capital G guidelines, where you have thousands of patients with heart failure or adult disease. And even in our space of genetic heart disease, I would say that the the vast majority of voices on the documents are people who spend most of their time in the adult, randomized controlled trial world, the RCTs and the thousands of patients. And when we as genetic cardiologists or pediatric electrophysiologists, people who are really focused on pediatrics, we're usually in the minority and almost never armed with the study of thousands. So you recently, we're gonna start with your spring break. ACC, the American College of Cardiology, you were very much instrumental in a study on hypertrophic cardiomyopathy. Now, hypertrophic cardiomyopathy, as we know, is one of the most common heart muscle conditions in the population, and it's quite prevalent in athletes. There are some nuances. We're not going to focus on those, but certainly, it's a disease that exists, throughout North America and the world. You have been part of the first large series of data on activity in HCM. Tell us about ACC.
Yeah, that was a great experience just a couple weeks ago now down in New Orleans, which happens to be where the 2005 Bethesda 36, the 40 of us met in New Orleans. So that may explain some of the writings back then. But really live HCM, which we're so excited about, and live or live long QT syndrome. These are two parallel studies, NIH funded, 3+ year prospective study, prospective enrollment of people, not necessarily athletes, people with either HCM, live HCM, or long QT syndrome, live long QT, from age 8 to 60. And this was really was conceived and birthed by Rachel Lampert at Yale, Charlene Day at University of Michigan, now University of Penn, at UPenn, and myself, where Rachel Lampert's also a shared decision-making minded cardiologist. And in parallel, we were permitting our athletes at Mayo Clinic to stay and play if that made sense. Meanwhile, about that same time in the early 2000s, Rachel created an ICD sports registry, which was viewed back then as blasphemy. There's going to be nobody in it because how can you have ICD and sports commingle? And so we joined forces and said, it's time to do a serious study and get more data rather than my experience at Mayo Clinic or your experience where you're at. And so that was the birth of LIVE. And now 10 years later, we presented the data for the first time. We started enrolling patients pre-COVID, enrolled almost 1,700 patients with HCM, of which 699 to be exact, were vigorous activity, vigorous exercisers, and the rest were moderate or couch potatoes. And the beauty of the study, the hypothesis was, as you and I would imagine it to be, that those who exercise the most will not have any more events, HCM triggered faints, cardiac arrest, tragedies, than those who exercise the least, who are the least active. And those who exercise the most will have a higher quality of life than those who are the most sedentary. We answered part A in this study because we haven't analyzed the quality of life instrument surveys. That's being done right now. But as to the first part, you take the lines of events of those who were the most active versus the least active, and you can just put them right on top of each other. They're superimposable. They're rare to begin with. So 95% of our hypertrophs during this follow-up period of 3+ years, 0 events. And the 5% who had events evenly split between the most active versus the least active. So part 1 of that hypothesis tested and fulfilled. And I think I will be really surprised if those who are the most sedentary happen to be happier than those who are the most active, because in every other study, people who are active do better. We know as physicians, that exercise is the best pill that we have. It's the best medicine that we have. And it shows that it is good medicine in patients with hypertrophic cardiomyopathy. And I think
Yeah.
that's good news.
It's wonderful news, and it's a very, I mean, it's a sizable data set. So congratulations to you and to Rachel and Charlene. Wonderful work, and so important. And there's so much fear out there about hypertrophic cardiomyopathy. Literally in the last 48 hours, one of the things about hypertrophic cardiomyopathy is that everyone can see it. So it shows up very nicely on an echocardiogram. So it's not uncommon for a room of people, cardiologists and radiologists and surgeons, to look at this data and say, that can't be good. That worries me. And so actually, when we go to the data and we see that actually it's nowhere near as frightening as the pictures, that's very important.
And most of those 1,700 patients, Shu, don't have defibrillators. So when we talk about doing sports and returning to sports, it does not have to be, and it should not be conditioned on, well, I'll let you play, but only if we install a defibrillator first. That's also a very wrong turn. If the disease deserves a defibrillator, so be it, but not because of what activity they want to do.
I think one of the other really important messages, and I say this in the clinic every week, the couch potato is going to have the same, adrenaline rush when they wake up late for school, or they have to run for the bus, or they're going up 3 flights of stairs because the elevator is broken. The less you do, your body then still is challenged. It's not like you don't face stress and adrenaline. And so the events that occurred in your cohort, important, they were uncommon, they were evenly distributed, and they didn't occur during vigorous exercise.
Right.
They occurred during very normal activities.
They occurred during this thing called life.
Absolutely. I'm sorry, I don't remember the exact circumstances, but they were, sort of, taking a walk, or, just having dinner, things like this. Very, very normal events.
Right. No, I think we're really excited about Live HCM. The paper ought to come out in the next months. It's just being resubmitted to JAMA Cardiology. So then the full length feature will be there. And then we are busy analyzing Live Long QT syndrome, and equally excited about that. That's also very large, on the order of 1,600 to 1,800 people with long QT syndrome, with the exact same question being asked, and we'll see what the answer is, and hopefully that'll be similarly good news. It should be. I mean, that certainly would gel with our very large and long experience with people with long QT syndrome who are not just vigorous by the definition of AHA vigorous, which that definition's not too impressive, but like serious athletes with long QT syndrome, from the ranks of little league to Olympians to professional athletes, and where we see no signal that setting is a clear QT agitator. So we hope that the general multi-center observation will yield the same piece of truth.
You had another impressive role at ACC, where I think it was about 76 or 72 or 76 high-level collegiate athletes with genetic heart condition were cleared by a genetic cardiologist and returned to play. And how did those athletes fare?
Great. So that is, I'm really excited about that work, and proud of the first author, Kate Martinez, who presented it. She's going to graduate from college and did this project. Wow. But this was really a follow along of what another one of my undergraduates, Katie Tolber, and she's now a first-year medical student in Milwaukee, Wisconsin. But what Katie Tolbert, the other Katie, did, and we published in Journal of American College of Cardiology just 2 years ago, was my personal 20-year experience with this issue of return to play, where, you know, I was pretty much alone or among the lonely few with this view, or some probably held the view but didn't come out of the closet, but where we were doing that since I joined the staff in 2000, because I told David Driscoll, I says, the way we're doing it doesn't make sense, is wrong, certainly can't be viewed as right, and we can do better. And so we have systematically over the last 23 years been analyzing and reporting what's happening to my athletes with their genetic heart condition, mostly long QT. I follow about 600 athletes with long QT syndrome itself, and then another 200 athletes with genetic heart diseases called something else. And what happened with that paper of that 600 and change was people said, yes, but those are just kind of ordinary athletes, right? You don't have very many good athletes, very many elite athletes. What happens at that level? And we had quite a few. In fact, of that paper that you're referring to, we contributed more than half. But with that, we joined forces, and we said, I reached out and phoned a friend, Matt Martinez, happens to be Kate's dad, and said, can you gather your retrospective cohort of your elites? And then Aaron Baggish, a sports cardiologist at MGH, can you do the same? And Dermot Phelan in the Carolinas, can you do the same? And from that, we gathered up 76 elites. And we define elite athlete as Division I university, so Baylor, University of Alabama, like real athletes, if you will, or professionals. And said, okay, if you made it to this level and you have a genetic heart condition, what does that participation, can that coexist, or is that oil and water? And 76, 50% HCM, 25% long QT, bottom line, three of those 76 athletes had a non-lethal event. 30% of those elite athletes owned an internal defibrillator. So again, even at elite level, you can do competitive sport without an ICD unless your disease deserves an ICD based upon risk features. And of those, like you said, with the setting, so one of the athletes, HCM and ICD, got shocked, but he got shocked not while playing his sport. He got shocked while making up macaroni and cheese in the kitchen, and a correct shock. So again, life is the setting where these diseases potentially can rear their head, not necessarily just because of what you might be doing on the field, on the court, at little league level, or now even elite level. Now, I'll grant 76 is not a big number, but it is the biggest collection to date of those athletes with our diseases participating at the highest level of competitive sport.
Yeah, and it's a lot more than we had before this spring. We had anecdotes and a few people tucked in to series. I have to mention one of my favorite papers of yours because it's about the CPVT group, and as the audience and I dabble a little in CPVT, and the OSPI paper I loved. I was privileged that Andrew Cron had me along to write an editorial to it.
Yeah.
What I liked so much about that paper is CPVT is another one of these very feared, because the opposite of HCM, people can't see it. So
Right.
HCM, when they see the echo, they get frightened, or the MRI, they get frightened. CPVT, it's like the boogeyman in the closet, because they can't get their fingers on it. And what was the main finding of the OSPI series? That was about 60 CPVT patients.
Right. And the same answer, very few events. It's more. Now, we follow that up in this Jack paper 2021. and have about 100 patients, athletes with CPVT. And the event rate, not surprisingly, is higher than long QT syndrome. So long QT syndrome, it's about a 1% chance per year of a disease-triggered event. In CPVT, it's about a 2 to 3% chance per year of a non-lethal event. And I think that's what's emerging, and what we knew to be true back then and see it now is these tragedies that happen from these diseases almost always happen in the undiagnosed and therefore untreated state. But once you're diagnosed, risk stratified, treated, counseled, the threat of the disease triggered event, it doesn't go to zero. I mean, I'm well aware. I take care of too many families to not be aware of the tragic exceptions. And those are tragic, but those are rare and the tragic exception. The vast majority of well-treated patients with these conditions can live large. And it's really, what do we do to do a better job of finding the untreated because they're not yet diagnosed? And that ultimately someday will take into questions of how should we be intentionally screening for the presence of these life-threatening conditions for which, when we know they're there, you and I almost always short circuit the tragedy from that disease.
Yeah, no, and that's an important role for our, our respective SADS, or, SADS International, SADS Canada, SADS US, the distribution of the good information, the true information, and dispelling some of these fears, getting people to the right providers. All those steps, are incrementally making these conditions safer, and people really are thriving.
Yeah.
In our last few minutes, and I do want to point out, Dr. Ackerman is coming to us. He's actually working. That's not his house. He's in a hotel. He's a traveling roadshow. And he's in Arizona right now doing the same genetic work that he does at the Mayo Clinic in Rochester, and also in Jacksonville. So he took some time out of his clinic day here to spend time with us, which I'm very appreciative of. And we could have Mike on every week, 114 episodes worth to delve into all these things. In our last few minutes, one of the conditions, and you and I had the privilege of being part of these guidelines, the arrhythmogenic cardiomyopathy. It's the one condition that gives me a bit more pause about exercise. The data that's coming keeps reinforcing that the patients who have done rigorous or intense exercise for a longer duration, so exercise dose, may have worse outcomes as adults. An important proviso, I've not seen pediatric data or data really that takes children and follows them for 30 years. This is very much I have an adult with this disease. By the way, what were you like as a kid? Right. So tell me a bit about how you're handling this, your approach. Are you gathering data? Give us a bit of your secret sauce.
I love the question. In fact, Greg, in the comment section, he just posed to us how much data has been collected with regard to ARVC. So great prompt, Greg. You and Shu and I are on the same wavelength. So I'm often asked, looks like, Mike, you let everybody play. And that's, number one, actually wrong. About 15% of every family that comes to see me to get requalified for sports, having been disqualified, after their shared decision-making session, they conclude that it's not worth continuing. So the notion that you and I, if we embrace this idea of working together with the family unit, that it will always lead to return to play, is categorically false. And I think we've debunked that myth that the other side uses that says you and I have to be hardline and just say no because the family can't say no. They can say no, they do say no. And where they tend to say no more is when we have more data. And where we do have more data is ARVC. So arrhythmogenic right ventricular cardiomyopathy, one of the ACMs. The data is there in both mice and man and woman that certain training styles, I would say, and certain sports do act as disease accelerators. Not maybe, not someday, but do. And so I can't, in good conscience, take somebody with clinically diagnosable ARVC and tell them, sure, I'll just sign your papers, keep running your marathon. Because I know they're engaging in a disease accelerating activity. But that has to be qualified a bit. That's not all ARVC. So there are those who've gone pretty draconian with ARVC and shut the engine down completely in the ARVC person at the stage of a positive genetic test by itself. And there, that can't be right, because we don't even know in that individual who all we know they have positive genetic substrate, will they ever be the penetrant one? Well, where they'll convert to the disease someday. And so to confine that person one of the best ways to make sure a family with ARVC doesn't follow genetic test recommendations and find out who's positive and who's negative, which is exactly what you and I want them to do, is to tell them, and by the way, if you're positive, but I can't diagnose it because I can't see anything, I will be kicking you out of everything. That makes zero sense. And so I personally, at the stage of genotype positive, but phenotype negative, meaning I know it's in your code, but I can't tell it otherwise, I let them do anything and everything they want. If they ask my opinion, should we take interest in marathon, I would say I probably would not because of the data. And then we say, and we're going to follow you every 6 months if you are an athlete in that state. And if we now move to a diagnosable condition without the genetic test result, then we've got to reassess the landscape. Now, for the person who has the disease, you and I didn't need the genetic test to make the diagnosis. I don't shut them down completely. I think exercise is still good medicine. And the data point is really high intensity endurance training with one specific genetic kind of ARVC called PKP2 ARVC. We don't even know yet if this disease accelerating phenomenon of high intensity endurance training is going to be relevant to all of the genetic subtypes. We only know that most clearly for one of the genetic versions, happens to be the most common of the genetic versions. But I think that's where I would be one that I do calibrate, and I do give them an exercise dose prescription and throttle things down, get them out of the 3C category, try to shift them to less endurance training activities. But to keep them on the couch doing nothing, that has to be as wrong as just telling them, go run a marathon twice a year. I think both have to be viewed as wrong, and we can do better than both of those approaches.
Yeah, no, absolutely. And in ARVC there are a couple of wobbly legs supporting the table. We're still recovering or living with the consequences of a lot of overdiagnosis from not knowing how to get our MRIs exactly right. There are people that were getting told they had too much fat, which is one of the signs of ARVC, and then we realized that MRIs are actually really good at showing fat in healthy people as well. And then the genetic underpinnings, as you say, about 45% of ARVC remains unsolved in genetic terms. And the significance, are you going to develop the disease just because you have the marker? I think we've got a lot of work to do there as well. So it's a shaky table, and I completely agree with your approach that it's hard to lean on it fully, but it's important to put a few provisos in, some safety and some intense follow-up. Absolutely. I then I've loved our conversation today. I think the other thing that you and I believe both agree on, first of all, lots of work to do. Wonderful that you're gathering data. There's a large group of people who have sudden cardiac arrest that is unexplained, or there's not a large, thankfully these things are rare, but in the population that have sudden cardiac arrest, we don't find a cause in, anywhere from 50% to, 50% is what's the number that keeps coming up. In those athletes who have had an unexplained cardiac arrest, are you putting in defibrillators and then returning to sports fully? Because it seems like that's the only way to go, even though we know that their recurrence rates are very low. But
Yeah.
I haven't had the courage to not implant an ICD in the unexplained group.
Yeah, no, I'm right there with you. Exactly. I don't think we have a choice. When we call it unexplained cardiac arrest and we run them through the drill, and we can't add a name to the disease. We even do genetic testing, thinking that they may be a pre-cardiomyopathic person, and we can't find anything. So they're stuck with a default label of unexplained or IVF, idiopathic ventricular fibrillation, which I joke, idiots don't know what's going on. Really, we don't have a choice. You have to have a defibrillator as secondary prevention, even though there's kind of the silver lining. When we can't give a name to it, the recurrence rate is almost zero. And so we're stuck giving a defibrillator, I think we're stuck with it, but we do the defibrillator and we return them to anything and everything they were doing that they love to do. I always describe it as that activity for you, O oxygen or O optional. And if it's optional, let's get rid of it. If it's oxygen, let's figure out a way to keep it, in play. But that's my approach with the unexplained cardiac arrest survivors. And like yours, I would have to think really hard whether I've had one of those have a recurrent shock. It's a very low rate of recurrence.
Yeah, no, absolutely. Mike, we're at time here. It's been absolutely wonderful to have you here, and I always learn something. It's such an enjoyable conversation. I think you and I could go on for hours on this stuff, and really, it is a privilege. And the partnership that we have in the SADS Canada with the SADS US is the only reason that we are delving into this new space for us. And having your guidance there it means the world to me. So thank you very much, not just from SADS Canada, but also from me personally. And a little known fact, Mike Ackerman was very kind. My daughter was doing an elective at the Mayo, and he made a lot of time to buy us lunch and chat with her and stuff. And that was one of the highlights of my summer last year. So.
Well,
Mike,
Shu,
thank you so much.
You're very welcome, Shu. And our professional relationship is very important to me and very satisfying, but our friendship trumps that a lot. I really enjoyed this. I'd love to come back. For the audience, we'd love to have you join us on Friday for our 3rd anniversary and SADS Live 114. But Shu won't say it, so I will close with this. A shout out to his daughter. She just matched and will be doing residency in pediatrics at Colorado Children's Hospital. So way to go. And I know how proud you and your wife are of your daughter and all of your children. So congrats to her, congrats to you, and congrats to SADS Canada. And I can't wait to come back on for another episode with you all.
Thanks so much, Mike. And so that's a wrap, everybody. Thank you so much for joining. What a great conversation. And the overwhelming message I hear is exercise is safe in the vast majority of people. You need your expert assessment beforehand. Exercise is healthy. It's the cheapest medication we have. And even in the most complex of heart conditions, we can find a way to get you and your patients active, get your families active. So that is wonderful news, and I'm so glad that we are gathering data. It's not easy to do. We have a CPVT study going, and talk about Mike 1600. We have about 30 patients in our CPVT activity study. So if you're out there and you want to enroll, either as a participant or you're a healthcare professional and you want to refer some to us, please do so. I'm excited. We're going to take a bit of a turn in April, and we're going to have Melanie Kerr on the show, and we're going to teach all of us a bit about genetics. We talk so much about genetics in this SADS space, and I don't know if we all know enough or understand. So Melanie Kerr, who's a genetic counselor here in Canada, is going to take us back to some of the basics, and it's going to be a two-parter. So it's going to be April and May. She's going to teach us a lot about genetics. So thank you so much for joining. We really appreciate your support, and we are in a bit of a rebuild in the Canadian SADS Foundation. It's worth popping by the website. We have a new board of directors, and next month I'm hoping to announce our medical advisory board. So honored to be part of a bit of a rejuvenation of Canadian SADS. So have a great 4 weeks, and I look forward to seeing you in April.